Good afternoon, everyone, or just about. We will just get started in a moment. Thank you for joining us. So because our opening is a bit lengthy, I think I will just get started. So good afternoon and welcome to our webinar, To Pump or Not to Pump, a discussion on automated pancreas systems in pregnancy, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. I am Rose Yeung, the Medical Director of the Office of Lifelong Learning and Physician Learning Program. And the Office of Lifelong Learning is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to addressing the challenges related to diabetes. So we'd like to start with a land acknowledgement and acknowledge we are on Treaty 6 territory, the traditional ancestral territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as being part of the Métis homeland. We acknowledge the many First Nations, Métis, and Inuit who have lived here and cared for these lands for generations. And we are grateful for the traditional knowledge keepers and elders who are with us today and those who have gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. I would like to start with some housekeeping info. So please use the chat function if you have a question about technical difficulties or L3 programs or services. If you have a question for the speakers, please use the Q&A feature of the webinar. And please review what has already been asked and upvote those questions you would like answered. We cannot guarantee that we'll be able to respond to all your questions. A recording of the webinar will be sent via email to all those who have registered. Participants can claim CME credits and complete a personal development activity using My L3 Plan tool. For more information, you can visit the QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional credits by completing a linking learning exercise. So today, Robin Lucciantonio and I will be discussing the risks and benefits and clinical pearls of using automated pancreas systems in type 1 diabetes and pregnancy. I will start by introducing Robin, a certified diabetes educator, registered dietitian, and certified insulin pump trainer. Robin has a keen interest in insulin pump therapy among special populations and using this advanced technology for reducing diabetes burden for all abilities of people with diabetes. Robin's main practice is with Garneau Endocrinology, a specialized general endocrine clinic here in Edmonton. And as I mentioned before, I'm Rose Yeung and an associate professor of endocrinology and metabolism with the Faculty of Medicine. I have a research interest in nutrition and diabetes, and I'm working to generate research and educational offerings that advance the rational use of nutrition and pharmacotherapy for diabetes care. So thanks so much. And with that, we'll get started with the slides. So let me just get the slides up. Okay, so hopefully this is correctly showing on everyone's screens. Robin, can I get that confirmation?
Yeah, I can see it fine.
Okay, super. So just a word on disclosures. Robin, you want to go ahead?
Yeah, so my disclosures are I am an employee for the Alberta Diabetes Institute working for the Vertex trials here in Edmonton. I do some presentations for Dexcom, and then I am a private pump trainer above and beyond my clinical practice.
And I have done some consulting for Dexcom and have been involved with some Novo Nordisk researcher as a sub-investigator, but I do not have any current clinical trials ongoing in the pump pregnancy area.
Okay. Well, we'll start by presenting our case. So really, this is a patient of both mine and Dr. Yeung's. So she was a 26-year-old female at Garneau Endocrinology with a recent diagnosis of type 1 diabetes in December of 2022 with positive GAD antibodies. We put her on a pump shortly after diagnosis because her ultimate goal was to get pregnant. A1C on diagnosis was 9%. No DKA on diagnosis was actually found incidentally with regular lab work. We worked hard to get A1C down in preparation for possible pregnancy. So at pump start, A1C was 5.7. she was struggling with a lot of lows when she was on MDI, and did have a hard time adjusting that Tresiba. So we transitioned her at Garneau to the tandem pump, and those lows resolved. I followed her for the first trimester, and then we transferred her over to the Royal Alec Clinic, diabetes clinic at 15 weeks. So really, when we're looking at these cases, we see them lots, and it's like, how do we proceed? We know that automated pump therapy is off-label for pregnancy. So do we let this patient continue on Control-IQ? Maybe we should have them switch to manual mode entirely. Maybe we're doing kind of a hybrid system of having them on Control-IQ in the evening and turning that off for the day and manually adjusting, or possible other approaches. So really we're looking, when we're talking about hybrid closed loop system, some of the other terminology around it could be automation or automated pancreas system. You may have seen like IAPS. That's all that means, is just a iPhone related automated pancreas system. The current limitations to a lot of these is that we still have to input carbohydrates consumed, and they're working with commercial algorithms, right? So we can't fudge a lot of what's embedded in that algorithm. There's a few systems, DIY Loop and IAPS, that users can adjust a lot more. And then there's CAM EPS, which is the Ypsomed software that's not yet available in Canada. And then the only pump that's in the market in the world, not yet available in Canada, is the Beta Bionics, and that's the iLet pump, and it's a weight-based algorithm.
So just a word on off-label use in pregnancy. So the Health Canada approval process for these automated pumps is needed, but it is very lengthy. And so as Robin just mentioned, the Ipso pump CanMeds is approved in pregnancy, but is in EU only. And then the hybrid closed loops have opened up the door to better technology and measurement to prevent hypoglycemia. So this becomes a discussion about shared decision-making and really making people aware of the risks and benefits that go with the hybrid closed loop systems. So just a word on targets for time and range. So as many of us know, using continuous glucose monitors, we now have targets set for using time in range, and the time in range actually is adjusted for pregnancy for type 1 diabetes to 3.5 to 7.8 millimoles per liter being the target range. And ideally, we want that to be over 70%. You can see in contrast to gestational and type 2 diabetes and pregnancy, the range is the same, but the target amount is actually 90%. So just to give a sense of what the guidelines from 2019 have shown us. And to just quickly review type 1 diabetes and insulin needs, in the first trimester, so here we can see that in this line here, this is the insulin as per units per kilogram per day. And in this line, this is the total daily insulin requirement. So it's just a little bit slightly different, but the lines are similar. And what you can see is if we're looking at the weeks of pregnancy down here, in first trimester, the total daily dose can drop. And then between weeks 24 and 28 weeks, that total daily dose can increase more than 130% on average. We also have to remember in pregnancy physiology, there is a slower insulin absorption later on in gestation. And that has been even noted to be 50% slower at 38 weeks compared to that at 8 weeks. So that's where you can see people, start to notice that it's harder to bolus and harder to correct insulins later on. And it's not just the insulin resistance, but it's also how that insulin is being absorbed. And then we will accept mild reductions in insulin needs near term. So I know traditionally we do counsel women about sudden decreases in insulin requirements, but we will accept mild reductions near term, and that's normal.
So looking at our patient, some of the MDI data here, we can see the daily statistics leading up to that pumps going onto the pump. She's having a lot of lows. Her total daily dose is about 20 units on 7 units of Tresiba. And we had played around with it. We had tinkered to 6 to 5 to 8, and she still was having lows, but having those postprandial rises. So just really showing like 20 units of her total daily dose prior to pregnancy and prior to pump. So then I switched her over to Tandem. My usual method for switching people from MDI to pump, if they're on Tresiba, is I have them hold their Tresiba a day prior. So we always do pump starts generally on a Tuesday at Garneau. So their last Tresiba dose is on a Sunday. And then I also put them in exercise mode. Really, the reason I'm doing that is for low blood sugar protection. And it's just so that Tresiba is coming out of the system appropriately. And you can see that even just on this half day, the total daily dose has dropped to 9.6 units. So a lot less insulin going in. And what exercise mode is it's really the target range is 7.8 to 8.9. Insulin will reduce at a predicted blood glucose of 7.8 and then suspend the pump at a predicted blood glucose of 4.4. The glucograph we changed preemptively to show pregnancy targets, knowing that this was a goal for her as well. So looking at the settings in more detail for Tandem, so there's kind of 3 options here, and I use them in different ways that likely are probably not as traditional, but have had great success. So again, using that exercise mode, transitioning from MDI to pump for that low protection as that long-acting insulin is leaving the system. And really the difference, between exercise mode and control IQ is that control IQ is your main profile in Tandem. That's your automation. That's the brains of the pump. Control IQ wants to keep people between 6.25 and 8.9, and it reduces insulin at a predicted blood sugar of 6.2 and suspends at 3.9. Alternatively, on the other side, it will increase insulin, predicted value of 8.9 and give an auto correction that targets 6.1 if you're predicted to be over 10. Exercise mode has the exact same approach for high blood sugars as it does control IQ, but the secret sauce of exercise mode is it gives that lower glucose protection because it's reducing insulin at 7.8 and suspending at 4.4. And then in the middle there, we have our sleep activity. Really what this can be utilized in a few different ways. These are the lowest target ranges that Tandem has. So trying to keep between 6.25 and 6.7. The bottom half is identical to control IQ. It's reducing insulin and suspending the same. The top half is a little bit different though. It's increasing insulin if you're predicted to be above 6.7. And you'll notice here, there's no auto corrections in sleep activity. So this is entirely basal modulation. The basal modulation can increase 4 times the current programmed rates. So we do see extensive modulation on this. And we can utilize this in a pregnancy setting to really tighten the range that patient is experiencing with their blood sugars. So, which is exactly what happened. 1 week after pump start, realized she was pregnant. And so then we had to adjust, right? We knew that her A1C was really good. Her average blood glucose was 6.4 at the time of pregnancy, positive pregnancy test. And we want to be under 6.5, which is excellent. So we knew that we needed to tighten a few things up. You can see that her total daily insulin is increased ever so slightly on the pump. It went from 9 to 12. We changed her alerts to reflect pregnancy highs. So I had her change it on her pump to 7.8. And this is really important that we're changing it on one system. There's nothing worse than having alert burden, never mind layering it with pregnancy and having every device you own alert and beep, and because they're going to turn it off and it's not going to be actionable. So the pump is attached to them. The alerts can go on the pump and turn it off on the phone. We switched her to sleep mode 24/7. And so she ran that 24/7, the lowest targets in tandem. And as you can see with pregnancy target, she's 96% time in range, estimated 6 weeks, 3 days by her last menstrual period. So some of the things that I initially do with my pumpers that are either preconception or newly pregnant is we really do a lot of education on infusion sets in pregnancy. I try to get this in right off the bat so that they have that knowledge and power going forward. I really encourage all my pregnant patients to be using either True Steel or the Sure T by Medtronic. It's a stainless steel infusion set, the lowest risk of any sort of kink cannulas and errors with infusion. And likely this is needed, 24 weeks onwards when we have that abdominal tightening, right? I'm not a big fan of the 90-degree sets in pregnancy. They're high risk for kink cannulas. I usually suggest angled infusion sets for the arms and legs. And longer cannulas are not always better. Sometimes we'll have patients say like, oh, I'm getting some pooling on the 6 millimeter, 90-degree set. So then they increase that cannula, but really that just increases the risk of that cannula kinking, and it's not solving the problem as to why we're getting pooling. So really, if I have any patients who have leaking at site, we're considering changing an infusion set. We're looking at where it is on the body. And then, I do look at insulin concentration. Concentrated insulin in pumps is off-label. This does require full adjustment of settings and should be addressed like 1-to-1. But I find as soon as patients have a total daily dose of, we have 80 here, I would say even 70, 75, or those boluses are 25 units on the regular, often they're going to have pooling. And as the pregnancy progresses, that increases the risk, of hyperglycemia and poor insulin absorption, right? So we really want to reduce that risk, and concentrated insulin could help in some of those circumstances. So again, pregnancy alerts, I counsel always that we're aiming for 3.5 to 7.8. First trimester, we're aiming to prevent lows, right? But I want them aware of that range. The Libre is not predictive, so the lowest you can set it for is 3.3. But again, if patients are nervous on lows, they're not going to get that predictive alert, even with the latest update. Again, alerts on one system, ideally on the thing that is attached to them, so the pump. Patients who are hypo-unaware or hypophobic, I think this is really important that we are setting our alerts early so that patients can intervene early. It's better for them to understand the system and see how the system is pulling back so that they can start to trust it. Those who are really hypo-unaware, there's a device called Sugar Pixel, and it's an actual clock that they can have in their house. It's random eye alerts. It's very loud. And it can be there as another option as well for people who are really, really nervous and have that hypo-unawareness. So looking more in depth to the sleep mode, this is a screenshot of the tandem pump, and a lot of patients often confuse sleep schedules and sleep. So the difference of the two is that traditionally with Control-IQ, we can actually schedule in sleep for when patients are asleep, right? It tightens up their nighttime blood sugars really well. But if they're pregnant, we want this to run 24/7, right? So we actually can go into options, activity, and then start sleep, the one that's red and highlighted here. And this will allow us to run it 24/7. It's basal modulation only, right? So there's no auto corrections, but then we have those alerts at 7.8 so the patient can go in and give some corrections if need be. And then the circuit trial in Calgary, they actually found adjusting these basal settings 20 to 40% higher to push that algorithm to the lower end. And one thing we have found is any patients who have, a lot of insulin resistance, they might already be on concentrated insulin, need really aggressive adjustments to the basal settings for this. Oh, Rose, you're muted.
Oh, thanks. So I just want to acknowledge Dr. Donovan, I think, is with us today. So thanks for joining. And I didn't get a chance to see if others from the team are here, but thank you. And we'd like to point out your work with regard to the real world use of Control-IQ in pregnancy, and did a qualitative series of interviews looking at whether, is Control-IQ 6.1 target adequate for that fasting blood sugar target. I think that was the clinical question that we had. And in this study, what they found was early adopters of Control-IQ safely used the system off-label in pregnancy. It reduced their diabetes management burden and improved their sleep. And the largest glycemic improvements were those with the lowest time and range at the pregnancy start. So you're going to get, possibly a bigger bang for your buck if your time and range is higher at the beginning. Participants with low time and range increase their time and range with Control-IQ use, and but that isn't to say because participants with high time and range maintained and increased their time and range with less burden. So I think it's really important to recognize, what patients are perceiving with the use of these technologies. And even though they are not, Health Canada approved yet, I think that it's very important that people know what their options are and what others have experienced by using these systems. So one of the first steps to ensure that your Control-IQ is properly working is to start looking at the fasting blood glucose. So here on this screenshot, you can see that as this person is sleeping, so this is midnight and this is noon. So here they are presumably sleeping. If the Control-IQ target of 6.1 is not achieved from the basal modulation overnight, that is an indication that basal rates need to be increased. So as mentioned by Robin, up to 40% increases may be needed in those adjustments. And what we typically do is we start with 10 to 20% adjustments and do this weekly until we are seeing that overnight is getting into the 6.1 range, and to ensure that basal modulation is working appropriately.
Yes, we can see here with the patient, I actually added in a 4 a.m. Time segment because she did trend down a little bit between 3 and 4 a.m. So we started at 4 a.m., did a 10% increase, and really gave this control to her to adjust on a bi-weekly basis and targeting a fasting blood sugar under 5.3. And she often would double check with a finger poke and was consistently under that as well. So it gave her a really actionable intervention that she could do as well. And this was something that she was able to carry forward throughout the pregnancy.
And so a quick word on insulin sensitivity factor or insulin corrections. So remember, a correction factor is the same thing as an insulin sensitivity factor, and it's basically how much glucose is anticipated to drop with 1 unit of insulin. So it's important to have the insulin sensitivity factor, or ISF, assessed continually as the insulin resistance progresses throughout pregnancy. So a usual calculation of ISF is 90 over the total daily dose of insulin in units. But note that you may need a stronger than 90 over total daily dose and it is not unusual for that ISF to be less than 1 for high insulin resistance cases. So that's where you start out in terms of calculations, but you keep on going and strengthening that ISF, which means lowering it if their corrections are not adequately correcting them. Correction factors or ISFs play a role in the algorithm for the basal modulation. So especially in sleep mode, because it's not going to do the auto corrections over 10 in sleep mode. So it's important to make sure that that ISF is reducing as that basal rate is increasing.
Okay, and correcting hypoglycemia. So the 15 grams is outdated, whether you be on just CGM or on a pump these days, because the technology is alerting patients early and earlier, and 15 grams is often causing rebound highs, right? And especially in the automated pumps. The automated pumps are working in a predictive fashion. So they're looking ahead of like 30 minutes. And if they're reducing insulin and then they're suspending insulin, there's times where a pump could be suspended, 30 to 60 minutes prior to the patient even experiencing a low. So 15 grams is no longer needed. With automated pumps, we say 5 to 8 grams to get rid of symptoms. They can have a snack afterwards. It's not always necessary, but it's really important that they're not over-treating, because if we over-treat, we're going to have a rebound high, and then they're going to have excess insulin to get that back down. And this cycle often causes weight gain. Weight gain causes total daily dose to go up. And this can be really impactful as the pregnancy progresses. And it causes patients a lot of anxiety, and it's frustrating.
So another word on pre-bolusing. So at the beginning, as mentioned with regard to the physiology of pregnancy and late pregnancy, the time for insulin to peak is delayed. And where possible, we should be giving that bolus dose 15 minutes pre-meal in the first half of pregnancy, plus or minus 10 minutes. And as that pregnancy goes longer, more than 20 weeks, we're looking at up to 45 plus or minus 15 minutes pre-meal, given that increased insulin resistance plus the delays in peak insulin action time. So if that CGM is showing that blood sugars are above the target pre-meal, it may be helpful to give that bolus for the meal and any correction, and then wait until CGM shows glucose is trending down before eating. Okay. And note that the bigger the bolus is, the more time it's going to take to deliver. So for example, in tandem, 25 units is going to take 8 minutes to fully deliver. And this is just a nice publication that really looked into the mechanics of this. And so just showing you pre-bolusing rapid-acting insulin 20 minutes before a meal results in substantially better postprandial glucose values than when given either at the start of the meal or 20 minutes after meal start. So it's a message, we know that a lot of patients struggle with pre-bolusing or planning, but where possible, we encourage them and provide that education that insulin peak is delayed the later on in pregnancy, and that is just part of the pregnancy physiology.
So in rare cases, we have patients who are extremely insulin resistant, and they're already maybe on concentrated insulin, and we've ruled out all the settings. They're at max settings, max basal, max correction, max carb ratio. And, we've had this in a few circumstances, and we can add in potentially some phantom carbs. Acknowledge the idea of phantom carbs is controversial, and it's not something we normally endorse at all. So there are certain circumstances. It's like one tool in your toolkit, and this could be a way of approaching, as long as everything else has been addressed, right? And it's really important that we're ruling out infusion set issues, bolus technique, food composition, timing. Is there a need for a split bolus and food composition? I think that's really important to address first before heading to this, but this is one more tool in our toolbox of adding in potential carbs to strengthen that correction to bring down those blood sugars postprandial.
Yeah, and what we're saying is fake carbs, right? Like they're carbs they're putting in, but they're phantom because they're not really eating. They're
That's
just
right.
saying eating because they want to correct.
Yeah. So really post-meal hyperglycemia, you know, this leads into this, right, of the phantom carbs. Is this a carb counting issue? Do we need stronger carb ratios? You know, where are we at with insulin resistance? You know, what is our pre-bolus timing? And we need to remember that protein and fat change the absorption of carbohydrates in a mixed meal. And this makes carb counting really, really challenging. There's several literature papers out there that show that 45% of meals, so that's half your meals, have post-meal hyperglycemia despite accurate carb counting. And we see this all the time with patients, right? And, you know, our poor patients will say like, well, I just had toast and peanut butter. And you're like, I inputted 15 and I'm still on this like high BG excursion and we can't figure out why. And, you know, for the dietitians in the group, we really need to be looking at the impact of protein and fat and how that contributes to post-meal hyperglycemia. So this could be a webinar in itself, and it's quite complex, but it has made the biggest impact for my patients is really acknowledging fat and protein. I'm a huge believer that patients should be able to eat whatever they want, and that includes their Friday night pizza with their family. And how do we give them appropriate bolus strategies for this, right? We know that, you know, we tell patients to limit their carb amounts for certain meals, but we also have not given them the tools of how fat and protein impacts their glycemia. So increasing dietary fat has been shown to reduce those early postprandial blood glucose responses. However, on the latter end, we see a really high rise, right? And then protein is something very similar. We see those postprandial blood sugar excursions between the hours of 2 and 6 after that meal, right? And they can be really challenging to address. Never mind layering a pregnancy on top of that. 10 to 30 grams of protein has been seen to produce the most stable postprandial BGs. And then without getting into too much of the weeds here, the Warsaw pump method and a percent increase are two of the most common ways to address mixed meals. And, you know, for the dietitians in the group, I've linked, you know, some of the literature at the very end so that you can look at the Warsaw pump method and the percent increases. But really, we're assigning carb ratios to the fat and protein because we acknowledge that these eventually metabolize into starch or glucose, and we need to address it with insulin. A lot of the times we need a split or an extended bolus. So Tandem does have a 2-hour split extended function. Medtronic is not able to use that in its automated form. So there's a little bit of differences there in the pumps. But generally we need 30 to 40% more insulin for higher protein and higher fat foods. And, you know, that's often not taught in regular carb counting, right? So before we get into phantom carbs and, you know, figuring out, tightening up those carb ratios, are they just having pizza? And do we need to assign insulin to the fat protein content of that meal?
So just a word on shared decision making using the AGP reports or the ambulatory glucose reports. These are available to the patients on Dexcom using the Clarity app. So a word on that is that it's not available in the standard glucose reading app. They have to download a separate Dexcom app called Clarity to be able to look at this AGP, which is the overlay of the last X number of days over 24 hours. And so I like to get people to look at their last 7 days because 7 days is usually what people can remember. If we ask them what they did, 2 weeks ago for breakfast or work, they often don't remember. So weekly review, I find, is a very useful approach to looking at the data. And then, once they've got the Clarity app and learned how to look at their AGP, if they don't already, Then the first step is just to look at the overall shape of the curve and whether it is within their target range. This target range can be set for pregnancy targets on their own devices. So that also has to be readjusted for pregnancy. And then what we do is we address any hypoglycemia patterns first. So for example, we would be asking and having a conversation about what's going on here, whether this is due to activity or missed snack or what have you, and then make a decision about how to avoid that hypoglycemia pattern to begin with, because oftentimes the hyperglycemia we're seeing is rebound from the hypo. Then we work on one thing to focus on per week, or we ask that patient if there is one thing they want to do differently and just be mindful of in the next week. And then they can check back the following week to look at their AGP to see if that actually worked. We generally start with a 10% change in 1 or 2 settings per week, and encourage that weekly review. So it's that art of maintenance that we really try to instill in patients and empower them with their own data. Now, note, this may not work very well if their day-to-day changes a lot, since that AGP is looking at the median reading. So if the day-to-day is changing quite substantially with shift work or certain exercise patterns, then what you may have to do is corroborate this data with the daily views. But I find that for many people who have a pretty standard work week, this offers a very nice way to summarize the data and see the general trends and give people a starting point of where to target their efforts for adjustments.
Yeah, so at the end of the first trimester with this patient, really it was getting her to the point of like what Dr. Yeung was saying is having that empowerment to change things. So her and I really worked on changing that 3 a.m., 4 a.m. basal rate that she could do independently and work on that fasting blood sugar and really just building the confidence with the technology, self-management. And then my goal with my patients is really the practicing of the pre-bolusing, the extended bolus, those sort of things. So as the insulin resistance continues and progresses in the pregnancy, it's not new to them. They are just adjusting the timing of it all. And you can see here that, heading into her second trimester here, she had a median blood sugar of 5.8. We want a median blood sugar of 6.5 or less, and she's 89% time in range, doing really well heading to the ALEC.
So these are her metrics at 34 weeks. So you can see here, 100% time in range, which is just incredible. But look at the amount, her total daily dose, the last one was showing us 18 units. She's now doubled that to 36 units. So just going to show you that 100% increase from coming to us. And I think that this is a really wonderful case of just showcasing the ability to effectively use technology and empowering the patient to make those changes and really be empowered to look after herself.
And I was going to say, Dr. Yeung, you can see that she did an extended bolus on that one as well. On the previous slide, you could see that she did the extended bolus here at 50 and, and prevented a low. So that would have been a fat protein meal and appropriately did it, right, to prevent it and kept it from going above too.
Yeah. So when we did see her at the beginning, she opted to continue the tandem control IQ for the pregnancy full time. She did not want to go back to manual mode. We let her know it was off label, and she thought that was going to be the best mode for her. And it worked out really well for her. So this is a snapshot of one of the MDI days back in April. And you just look at the ups and the downs. And then the last 90 days of her pregnancy, her A1C at delivery was 5.9. So she did really just very exceptionally well on this. Robin, was there anything else you wanted to add to this slide?
No, I don't think so.
And then she had her baby at 38 weeks and 1 day, and a healthy baby, doing well, breastfeeding well. And we had to do, you know, a lot of preparation to help her understand what to have signed coming into the hospital and charting appropriately to help the other team members know that she was very comfortable being on her automated pump throughout labor and delivery.
So really this slide is just showing how exceptional her blood sugars were at actual delivery. We put the red arrow in to show at 2:48 in the morning, those are her blood sugars. So she managed it with the tandem pump, which is really incredible, right? Like we're not seeing a blood sugar over 7 there, and was able to maintain it, no lows. And really important for all of our colleagues that ipumpit.ca is an AHS protocol. And that's one thing we have found with our pumpers going over to labor and delivery, is sometimes all the nurses are not aware that is an official AHS protocol that pumpers can remain on their pump in automated fashion. So really for our postpartum changes, we want the profile ready to go for postpartum. We don't need to make more decisions than we need to in that moment. It's really important that we are pre-entering it in the tandem pump, which will allow you to do it. You can have, I think, up to 8 profiles, but you can label it. So it can be labeled as postpartum. It should be 50% less than your pre-pregnancy settings, okay? And they say label it, and then they just activate it. There's a few different strategies of turning it on when patients are ready to push. Some turn it on shortly just afterwards. It's really just dependent on the patient and maybe what's leading up, their blood sugars are like leading up to that point. Another aspect you can do is choosing the highest targets at delivery. So exercise mode in this case would be a really great addition to that postpartum profile, right? To reduce that risk of low blood sugars. So this was postpartum day 1. So she's in her postpartum profile and she's still having a ton of lows, right? You can see that there, so 4% lows. Her total daily dose has come down quite a bit, 24.7 units, but still having a ton of lows. So then her and I happened to talk on day 4 postpartum because she was having all these lows. I made 0 changes to her settings. I just asked her to turn on exercise mode, right? So you can see that the night cleaned up immediately. There's no lows overnight. You can see that she's able to bolus for her food, not having any hyperglycemia or hypoglycemia, right? She's 98% time in range. And her total daily dose has dropped substantially to 9 units, right? And so this is kind of the beauty of using these different targets to prevent that hypoglycemia. There is a lot of basal suspensions here, like that's the pink blocks there, but we know like insulin active time and duration is about 4 to 5 hours. So we know she's getting some overnight. Blood sugars are good. There's no ketones. She's presenting really well. She's doing well.
So just a word, we wanted to acknowledge Dr. Donovan and team's circuit trial that is going on, looking at closed loop insulin delivery in people with type 1 and pregnant. So the goal of that study is to investigate if automated insulin delivery using Control IQ can improve glucose control, reduce high glucose mediated poor neonatal outcomes, lessen the burden of diabetes self-management, and result in healthy pregnancies compared with standard care. And so that is the question. The target range, 3.5 to 7.8. Their N is 90. And so the inclusion criteria are here. So type 1 for at least 12 months, an ultrasound confirmed viable singleton pregnancy, less than 14 weeks, gestation on intensive insulin therapy, or pump, and there are the A1C criteria of either more than equal to 6.2 and less than 10% during pregnancy. If they have an A1C more than 10, they may participate if they achieve less than 10 before the required enrollment date and they have access to email. The exclusion criteria are a total daily insulin dose of less than 8 units or more than 250 units per day, the current use of an automated system already, or women with a GFR less than 45. And I'll defer further questions around circuit to Dr. Donovan and team. We have included some studies using hybrid closed loop therapy in pregnancy for your interest in case you want to look at more information. And we're open for a few minutes of questions. So thanks so much. Questions, comments? Dr. Donovan, did you want to let anyone know any further information that I missed on circuit? Feel free to post in the chat. I don't know if we can, oh, here we go. How do I'm trying to invite a comment here. Tassia, can we get help here? Okay, a question on what has your experience been using the 70G pump? Robin, you want to answer that?
Yeah, sure. The 780 can be great because it has a target of 5.5. I do, and I think this is often mystified us because with the target of 5.5 and tandem of, I guess, 6.1, I see better blood sugars at the end for postpartum with the tandem pump than I do the 780. And I think it has to do with the delay of the algorithm updating by 6 days. They're both excellent pumps. I think the automation is really the way of the future. But with the 780, you can only adjust the carb ratio and the insulin action time, and then I guess the target, which we would choose the lowest target. But you can only adjust the carb ratio. Whereas with the tandem, we can adjust everything with the exception of insulin duration. So it gives you a little bit more wiggle room to push the algorithm to that stronger end or that lower end. So I don't see as good of blood sugars at the end. Whether that makes a difference statistically, I don't know. But I know as an educator, there's not as much to do. That's my experience.
And I might, I'll invite Dr. Donovan to join because I finally figured out how to add her.
Okay, thanks, Rose. Can you hear me now?
Yeah, we can hear you.
Okay. Okay. I'm sorry I had to join part way because I got tied up in clinic. So I may not have understood things correctly. I missed the initial introduction of your patient. A couple of things. I did join where you was something about the findings of the circuit trial. So just to be very clear, we're not done with the circuit trial. We're still recruiting and we don't have any published findings yet. What we have published is some out of study patients that were early adopters early on in our experience. So that's all we've published from there. So still very actively recruiting. Thank you. Just a couple of things about the differences between the 780G and the tandem that I think are worth pointing out. I can say that for the although you emphasized phantom carbolysis, I find that's super important with the Medtronic pumps, but not with tandem. I'm not telling people to phantom carbolus at all in pregnancy. I'm actually just adjusting their pump settings. And there was a nice paper, lead author was the senior engineer who developed the algorithm for Control IQ that actually found that you may be able to optimize the settings. This is outside of pregnancy, but using ISFs as aggressive as 66 divided by total daily dose, insulin to carb ratios as little as 150 to 200 divided by total daily dose. And basal rates, as you pointed out, need to be much more than what's actually being delivered. And that was just one point I wanted to make. The other was, with the 780G, we're finding a huge need to do phantom carb boluses as pregnancy goes on. And that it seems to be important, the split between basal and bolus, because the basal modulation is readily shut off if you bolus too hard. So it sounds kind of counterproductive, but in discussions with Katrine Ben Halima, who is the PI for the 780G in pregnancy study out of Belgium, she's actually making insulin to carb ratios less aggressive and then telling people to enter more carbs. So it's really quite complicated. I have to admit, I don't have a ton of experience yet, and I'm still kind of trying to learn how to make things work. I was really interested in your the case that you showed at time of labor and delivery, because I have to admit we just haven't struggled with lows in our higher, in a large number of women the way you did with that. So I know you said that you put her basal rates to 50% of her pre-pregnancy. I assume that you also gave her weaker correction factors in pre-pregnancy and weaker insulin to carb ratios in pre-pregnancy.
Everything was reduced to 50% pre-pregnancy.
Yeah. So that's interesting, because we often don't even reduce that much as you did. And we often don't need to take people out of sleep. So I wonder if that was somewhat unique to your participant. I think when we first started, we were very cautious and increased the, to take them out of sleep activity or put them into exercise activity. And we just found it was just resulting in people running high. So that was just a word of caution that's a nice example to see. And thanks for presenting that. It hasn't been the bulk of our experience for what it's worth. And I'll just stop there. Thanks for the opportunity to comment. And thank you
so much. That's very valuable. And I think that this is, one of the counseling points I do make to all women is that their experience may be very different depending on the multitude of factors affecting their postpartum insulin sensitivity, and that it is a bit of a guess and test for the first few weeks as their bodies adapt and whether they're planning to breastfeed, etc. So, my practice has been to reduce everybody's settings, both pre-pregnant or reduce all their settings, their basals, ISF, carb ratio, everything to 50% of their pre-pregnancy. I know that that's not everybody's practice, but that is what I've been doing. And I've been noticing I have both hypo and hyperglycemia post, and we just have to make those adjustments quickly within days of delivery. Ideally, I try to see them within a week of delivery. Other questions here. We can stay on maybe for a couple more minutes. Wondering about carb counting. I noticed that in the case study, the carbs are rounded. How precise should they be with carb counting? Robin?
I would say, I think we know that carb counting is not leading to accurate blood sugars, right? Because of the fat and protein. So for carbs, I often think like 15 to 30 grams is not going to make or break it. I think it's the protein and the fat that we actually need to be focused on to catch, because that is what's going to happen with the post-prandial hyperglycemia, right? So I think it's not so much the carbs, it's looking at the big picture of how do we manage the entire meal. And because eating a bag of Skittles is really easy to bolus for, but how do you bolus for pizza?
And a couple more meal related questions. How do you coach a pregnant lady to delay eating her meal if she is experiencing hyperglycemia pre-meal? And followed by, you mentioned 10 to 30 grams protein for meals, but a question regarding how much fat is too much in your experience.
Yeah, so I think, one of the strategies is, and it was one of the ADA presentations that talked about super bolus. And so if they have specific times that they are eating, the super bolus looked like basal rates increased at those exact meal times. So that could be one strategy to head off heading into a meal. It could be them giving a correction before they're even going to bolus for their meal, and just allowing that correction to go forward to bring them down a bit so that arrow on their Dexcom is steady, right? Versus any sort of 45-degree. And I think it's utilizing that and depending where they are in their pregnancy. So it doesn't mean that the meal has to be delayed. It's just them having understanding on insulin impact on their blood sugars as they head into the meal and what strategy they're using. And then for the second part, 10 to 30 grams, one of the papers at the very end talks a little bit about fat, but usually 11 grams of fat is considered one fat protein choice. So, once you start getting over 22, 33 grams, you're going to really notice that things are going to be really high 3, 4, 5 hours later. And depending on how much fat, they say 3 to 4 fat protein choices can have delayed high blood sugars, I think as long as 8 hours. So we've really underestimated the impact of fat and protein on blood sugars. And I think that circles back to how accurate we have to be on carb counting. And it's not so much the carbs. Yes, we need to identify and input it, but we have to have that knowledge for the back end down the road.
Thank you so much. And so I think there we will close it. And just another plug, if you're in the Calgary area and have women who fit the circuit eligibility, please be in touch with Dr. Donovan's team. It's very exciting, and we definitely need more data in this space to help encourage, especially our, Health Canada and others, about policy changes needed to support pregnant patients to adopt these technologies further. And thank you so much for listening. We do ask that you fill the evaluation, and please do let us know if this was of interest. Please let us know what you might want to see in future, whether diabetes and pregnancy or diabetes in general, what you'd like to see for future webinars. So thanks for attending. Stay warm, stay safe, and hope to see you next time.
Thanks, everyone.